All right, so welcome to the second tutorials of Krok 2 2016 booklet. Krok 2 2016 booklet. Let us not waste much time. Let us start. So we have a 30-year-old patient who has been suffering from headaches and suddenly developed extreme headache after lifting a heavy load, as if he had been hit over the head. There is nausea, vomiting, slight dizziness are observed. In a day, he developed pronounced meningeal syndrome. Pronounced meningeal syndrome. Again, I believe I should ask you differentials. You can give me like 3, like 4 or 5. Body temperature is 37.6. A doctor suspects subarachnoid hemorrhage. Subarachnoid hemorrhage. What additional examination is necessary to confirm this diagnosis? And I know there's a question that Uche loves so much. Uche knows practically everything about meningism. So over here, we're looking at what? Lumbar puncture with investigation of the spinal fluid. To be specific, cerebrospinal fluid, also known as liquor. We know this thing because we've solved this like many times. A worker of a blowing shop complains of headache, irritability, slight impairment. He sees everything as if through a net. Okay, that means something is covering sort of the eyes. Yeah. Objectively, there is what? Hyperemic sclera, thickened cornea, decreased opacity. Again, visual acuity is 0.8. The left is 0.7 in the left and 0.7 in the right. The worker uses no means of personal protection. What diagnosis is most likely? Again, seeing through things as if he's seeing through a net, or seeing things as if he's seeing through a net is a sign that something is blocking what? The eye. That more or less that's like a cloud. Exactly. So over here, you are looking for what? Cataract. You are looking at for cataract, which is just like a clouding that develops in the lens of the eye. So your answer here is C. We've done these things. We've done them. A 45-year-old woman is undergoing treatment for active rheumatism. Active rheumatism. Combined mitral valve failure. Again, if you hear of rheumatism, you know that some of the complications in the heart could be what? Mitral problem. Now we are having what? A combined mitral valve failure. During her morning procedures, she suddenly sensed pain in the left hand, which was followed by numbness. Pain and numbness continued to aggravate. The skin of the left hand is pale and comparatively cold. Pulse in the hand arteries is absent. So there's no pulse. There's no pulse. What treatment tactics is most efficient? What treatment tactics is most efficient? So now the clue here is that there is no pulse in the hand what? Arteries. There is no pulse in the hand what? Artery. And this could be due to an obstruction in the circulation. This could be due to what? An obstruction in circulation. And by obstruction in circulation, what do? This means there's what? Embolus. Embolus. That means something has broken from a place and has gone to dislodge at that what? Artery, for which blood is not passing through, or for which there's no what? Pulsation. And so therefore, what do? We have to do what? Remove the embolus. We have to remove the embolus. And for this reason, we do what? Urgent embolectomy. Urgent embolectomy. So your answer here is what? Is B. Is B. All right. A 10-year-old boy had a case of viral hepatitis B for 4 years ago. Currently, the assumption was made about the formation of hepatic cirrhosis in the patient. Now, what additional investigation can clarify the diagnosis? So this person has developed what? Hepatitis B. And we know that hepatitis B can lead to what? A chronic what? Condition. And by chronic condition, it can also lead to what? Liver cirrhosis or scarring of the liver. Scarring of the liver. And usually, so now when we have to do with liver cirrhosis, one of the golden two, or let me just say diagnosis, is usually based on blood test, medical imaging, and liver biopsy. So these are the tests that we do to check for the presence of chronic or liver cirrhosis. And the golden standard for diagnosis of cirrhosis is always a liver biopsy. Always a liver biopsy. This could be through a percutaneous or a fine needle approach. Fine needle approach. These are the things that we do if we want to, confirm our diagnosis. Now, for some reasons, I don't know why Krok says this is renal needle biopsy. I don't know why they use the word renal needle biopsy. Anyways, I stand to be corrected, but I think the answer should be what? Liver needle biopsy. Liver needle biopsy. That should have been the right answer for me. However, I stand to be corrected why they chose renal needle biopsy. So please, if you have contribution at the end, do well to bring it up so that we learn together. But for now, I know the answer to be what? The answer is renal needle biopsy. But for what I know, this should have been what? Liver biopsy. A 40-year-old patient has acute onset of disease caused by overexposure to cold. Overexposure to cold. So I know Dami loves overexposure to cold a lot, because one of the things that overexposure to cold can lead to, that we know, according to Krok, that we have seen in Krok, is what? Pyelonephritis, isn't it? But don't also forget that the reason why sometimes they ask us to put off the aircon in our rooms and things like that is because of what? Pneumonia. Pneumonia can ensue due to overexposure to what? To cold. So put that at the back of your mind as well. Apart from pyelonephritis, you can also be looking out for what? For pneumonia. Now they said temperature has increased up to 39 degrees. There's foul smelling sputum is expectorated during coughing. Now, various moist crackles can be auscultated above the third segment on the right. Blood test leukocyte is 15. That shows there is a sign of infection. Stab neutrophils 12. ESR 52. On X-ray, in the third segment on the right, there is a focus of shadow 3 centimeters in diameter, low density with fuzzy smooth margins, and a clearing in its center. What disease is most likely in the given case? Guys, do you remember we talked something about abscess and gangrene of the lungs before? Yes. And we said one of the differentials of this kind of thing is what? Either an abscess or a gangrene, or pulmonary abscess and pulmonary what? Gangrene. Now, if you look at this question, the answer is actually pulmonary what? Gangrene. Pulmonary what? Gangrene. And you remember, I categorically state that in pulmonary abscess, the expectorant does not really come with odor. But in gangrene, it comes with what? That foul smell or that odor, if you can remember. But in practice, sometimes we misdiagnose pulmonary abscess for pulmonary gangrene and vice versa. So just to let you know this, because we've talked about this before. We've talked about it, and even the answer at that time was even pulmonary what? Gangrene. Pulmonary gangrene. And everything here is saying that we could be looking at what? A pulmonary gangrene. But like I said, it could also be what? Pulmonary what? Because they are all both what? Differentials. And that's why over here, the answer that they went in for is what? Pneumonia complicated by an abscess, which, of course, is a differential. We can take it that way. So over here, your answer is what? Is E. But usually in abscess, the sputum or the expectorant doesn't really come with odor. But of course, we are learning, so we move. All right. Now, an electro gas welding. I've asked this question before. Welding. Always, you know why they use that to cover their faces, isn't it? To prevent some of the flashes or whatever it is to enter into their eyes, isn't it? But let's get a question. The question says what? An electro gas welding operator working at a machine workshop performs welding and cutting of metal, which is accompanied by intense UV radiation. His welding station is equipped with efficient mechanical ventilation. What occupational disease is likely? Of course, you are looking at what? Photoelectric ophthalmic. What about what type of pneumoconiosis can a welder possess? Who can tell me?
Metal.
Someone say something.
Heavy metal.
Heavy metal. Okay. All right. So here your answer is what? Photoelectric ophthalmic. All right. A 48-year-old patient was found to have diffuse enlargement of the thyroid gland. Up until now, you should know all of these things about differentials with enlargement of the gland. You should know. Oxophthalmia is present. Weight loss is there. Sweating is there. What type of goiter is it? Who can tell me? Now we are having ophthalmia. We are having weight loss. Increase in BP, whatever. What type of
Diffuse?
Come again. Diffuse what?
Toxic.
Is it toxic or non-toxic?
Toxic.
Toxic. Exactly. Because we said anytime we are having increase in the thyroid gland or in the thyroid gland accompanied with signs and symptoms of hyperthyroidism, we said this is what? Toxic. We said this is what? Toxic. So this is what? Toxic goiter, diffuse toxic goiter. We can also have what? Nodular toxic goiter. Okay. So what kind of therapy is it? That means that there is what? Hyper secretion of what? Thyroxine, isn't it? So if there's hyper secretion of thyroxine, what do you give? You want to give something that will lower the thyroxine. And what do we give? We give mecazolil. So here, your answer should what? Should be A. Your answer should be A. A woman addressed a doctor with complaints of increased body temperature up to 37.8 and moderately sore throat for the last 3 days. Objectively, mandibular lymph nodes are enlarged up to 3 centimeters. The tonsils are hypertrophied, covered with gray coating. So this is a form of what type of inflammation? Gray coating is what type of inflammation? You can tell me. What type of inflammation is gray coating?
Venous inflammation, also diphtheria.
Fibrosis, exactly. Which spreads to the uvula and the anterior pillars of the fauces. What diagnosis is most likely the cause? And of course, you people have already told me the answer. So over here, we're looking at what? Diphtheria or oropharyngeal diphtheria. Oropharyngeal diphtheria. A 48-year-old woman complains of constant pain in the upper abdomen, predominantly on the left, which aggravate after eating. Diarrhea, loss of weight. A patient has alcohol use disorder. 2 years ago, he was diagnosed with a case of acute pancreatitis. So again, if you have acute condition, what can it lead to? It can lead to what? A chronic condition. So we have acute. So what it means is that we can have a chronic condition or complications of the acute pancreatitis. The amylase is 4 grams per hour, whatever. Feces analysis, steatorrhea. Again, it means that there's fat. Criteria, sugar is 6.0. What treatment should be prescribed? So again, with a history of acute pancreatitis 2 years ago and alcohol, and of course, an alcohol abuser or he being alcohol abuser, patient might have developed to call what? Chronic pancreatitis. Chronic pancreatitis. And in chronic conditions, what we give is what? Panciniform forte. Panciniform forte. That's what we give for acute condition. Acute pancreatitis. Contracol is given for acute, panciniform forte is given for chronic condition, whilst contracol is given for acute pancreatitis. Now, over here, we are having what? Chronic condition. And that's what over here, your answer should be what? Panciniform forte. Panciniform forte. All right, so your answer is D. In 10 hours after eating canned mushrooms, a 27-year-old patient has developed diplopia, bilateral ptosis, disrupted swallowing, shallow breathing with respiratory rate of 40 per minute. There's muscle weakness. There's what? Paresis. What measure should be taken first? Now, somebody coming with this, of course, this is an emergency what? Case. It is an emergency what? Case. And by protocol, what do we do in emergency case? You always assess and stabilize your ABC. Lawrence asked me about my management principle or my management procedure. So always in a case of emergency, always assess and stabilize your airway, your breathing, and your circulation. Yes. So now in this patient, obviously, we are having a problem with patency of the airway. We're having a problem with patency of the airway. That means opening of the airway is one way or the other is being what? Obstructed. Perhaps maybe due to what? Of course, due to injection or eating of the canned mushroom. Maybe the person is allergic to it or something like that. So that led to these sort of what? Complications. So in that case, what do we do to help the person to breathe? Because our primary care is what? Is airway. Airway. So to help with the airway, we have to immediately do what? Intubation. Because without airway, we cannot consider other things. We can't consider the breathing. We can't consider the circulation. So your first or your primary work is what? To intubate the person and to give the person what? Artificial respiration. Artificial respiration. Artificial respiration. And you know the normal breathing rate of a person should be around 16 to perhaps 20. So for us to double it, that means this person is in a grave condition, cannot even breathe. All right. So over here, your answer is what? Is C. Intubation. Intubation. All right. Of course, intubation we can give our glucocorticoids and stuff like that to reduce the reaction. A 32-year-old patient complains of reddening, burning, and sensation of a foreign body in the right eye. Foreign body in the right eye. The disease is acute. On examination, visual acuity on both is 1. In the right eye, there is hyperemia and swelling of the conjunctiva. That means the eye becomes red, isn't it? Superficial injection, there is purulent discharge in the conjunctival sac. The corneas are clear. The color and the pattern of the iris are unchanged. The pupil is mobile. What is the diagnosis? Now, nothing is wrong with the cornea. Nothing is absolutely wrong with the cornea because the cornea is clear. Iris is fine. Nothing is wrong with the iris. So now the problem here is what? Is the conjunctiva. And of course, we are looking at the case of what? Acute conjunctivitis. Acute conjunctivitis. Don't forget, this disease is having what? An acute onset. The disease is acute. So over here, we are looking at what? Conjunctivitis. Sorry. We are looking at what? Conjunctivitis. Conjunctivitis. So your answer here should be what? Should be D. Conjunctivitis. In glaucoma, there will be increase in what? Intraocular pressure. And they will have given you the value for that. All right. A patient is on the sick leave for 4 good months continuously from the date of injury. The treatment is ongoing to last for another 1 to 2 months. Guys, who will give this kind of sick leave? Quick. I know Blessing loves this question, but anyone can give the answer. MSEC. So over here, your answer is what? Is B. We've talked about this in our hygiene presentation. So please do well to watch the hygiene presentation or hygiene tutorials. Monthly dysentery morbidity in the region given, monthly dysentery morbidity in the region given in absolute figures is as follows. Absolute figures is as follows. January 6, blah, 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 blah. Now, the annual total is 220 cases. The annual total is 220 cases. What graphic presentation would provide the best visual for monthly deviation of dysentery morbidity from the average? And over here, we are going to look at what is called the radar charts. The radar chart. And the radar chart are simply charts that are used to visualize multivariant data. They are used to visualize multivariant what? Data. Multivariant what? Data. And basically, they compare two or more items on various features. Again, they are also used to compare two or more items on various features. For instance, let's say we want to compare two antidepressant drugs, okay? We want to compare two antidepressant drugs on the basis of what? Efficacy, prevalence, and interaction with alcohol, and then the relief of, or the continual relief over time. So that means you're comparing two things, which are the antidepressant drugs on the basis or on the features of what? Of efficacy, prevalence, interactions with alcohol, and so on and so forth. So that is the concept of a radar chart, or radar chart. That's the concept. Now, in this question, we are comparing what? Months to the morbidity or to the disease occurrence. We are comparing months to now the feature here is what? The disease occurrence in January, in February, in March, April, May, up to what? December. So that's what we are doing. Now, don't forget, if you are doing how do you call it? According to years, you remember we talked about it in one of the, how do you call it? In one of the hygienes. According to years, we use a different kind of what? Chart, or a different kind of what? Graph. We call it the trend graph. The trend graph. So that one, 2020, 2021, 2018, 2019, 2020, you are checking the trend of a particular what? Disease. So that one, we use a trend chart. But this one is what? Months. We are looking at the morbidities or the disease occurrence in months in a particular what? Year. And that one, we use what? We use our radar chart, the radar chart. This is hygiene. Don't ask me how I got that. All right, so we have a 30-year-old woman complaining of pain in the heart area. It is aching and piercing pain that arises primarily in the morning hours in autumn and the spring. I believe the question is familiar to you. The pain irradiates into the neck, back, abdomen, and is attended by a rapid heart rate and visual low vital tonus. Condition occurs independently from physical exertion. It occurs independently from physical exertion. In the evening, her condition improves. Somatic and neurological state and ECG have no pathologies. Again, you are familiar with this question. So, of course, what is your clinical presentation? And this is what? a somatized what?
Somatized depression.
Exactly, depression. Somatized
depression.
depression. As simple as that. As simple as that. In somatoform autonomic dysfunction, it is more similar, but that one comes with effort, or it comes with an effort, or it comes with some exertion. So though there's no pathological problem on ECG or in the brain, but because of maybe exercise or because of some activity, these symptoms or these cardiac symptoms are coming. That is what somatoform autonomic. So over here, your answer should be what? Should be A. We've talked about this severally, so let's not rely on it. A full-term baby born from first non-complicated pregnancy with complicated labor was diagnosed with cephalohematoma. That means injury in the brain, technically. Even without continuing, you should know what could cause an injury to the brain in a newborn baby. Of course, you know already. Now, on the second day of life, let's continue the question just for the benefit of those who just join us. On the second day of life, the child developed jaundice. On the third day of life, there appeared neurological changes: nystagmus, Graves syndrome, urine is yellow, feces are golden yellow. The mother's blood group is blood group A, Rh negative. The child is A positive. But now I know there was a question like that before, but then what we know, can this person be developing Rh incompatibility in their first pregnancy?
Yeah.
Sorry?
No.
Not really.
Not really.
No,
in
no,
first pregnancies, we hardly see it. Exactly. We discussed this. In first pregnancies, we hardly see it. So although the child is positive, the mother is negative. But this is what the first pregnancy. Now, on the third day, the result of the child's blood test is as follows. Hemoglobin is 200, erythrocyte is this, bilirubin is 58, due to the presence of unconjugated bilirubin. Hematocrit is 0.57. In this case, the jaundice is caused by what? Guys, look at it. A child, a full-term baby born from a first non-complicated pregnancy. So then the pregnancy itself is non-complicated, but the labor is complicated and was diagnosed with cephalohematoma. So what is the diagnosis? Who can tell me? Your answer is what? Birth injury. Exactly. So craniocerebral birth injury. Craniocerebral birth. It's just like saying this, there's what? Birth trauma. As simple as that. So the answer is what? Birth trauma. Birth trauma. And the bleeding is what is leading to what? The increase in the unconjugated what? Bilirubin levels. Because we said in terms of bleeding or in the breakdown of red blood cells, we can have what? A lot of what? Unconjugated bilirubin being present. So over here, your answer is what? Is C, from the history. From the history. All right. Now, on the fourth day after recovering from a cold, a patient was hospitalized with complaints of a solitary splitting of mucoid sputum. On the second day, there was a single discharge of about 250 mils of what? Purulent blood-stricken sputum. Patient's condition is moderately severe. You realize that over here, they didn't really talk about the smell, isn't it? They didn't really talk about the smell of the sputum. But it says it's purulent. Okay. Condition is moderately severe. Respiratory rate is 28-30. Pulse is 96. BP is that. The respiratory above the lung is vesicular, weak above the right lung. What are the various? There are various moist crackles above the lower lobe and amphoric breath near the angle of the scapula. What is the most likely diagnosis? Again, anytime there is fluid out of this, like this, from the lungs, I've told you guys that you are thinking of what? Either an abscess or you are thinking of what? Either a gangrene, isn't it? Yes. So over here, your answer should be what? An abscess formation. So acute pulmonary abscess formation. Abscess formation. Abscess. In gangrene, they will talk about what? The smell, like we discussed in the previous one. All right. A 46-year-old patient with a temporarily undetermined diagnosis was prescribed with pyrocentesis. For those of you who follow me on my social media, on Medent, I think last week or so, or last 2 weeks, I presented something about pyrocentesis. And I think one of the people who commented on was Uche. So based on the results of the X-ray, now the pleural puncture yielded, the puncture yielded 1,000 mils of liquid with the following properties. 1,000 mils. It is clear, specific gravity is 1.1, protein is 1%. River test is negative. I shall explain to you what the river test is. Erythrocyte is 2.3 in the field of vision. What disorder are these pathologic changes characteristic of? What disorder are these things characteristic of? So first of all, a pyrocentesis, also known as the thoracentesis or the pleural effusion treatment. This is actually what? A pleural effusion what? Treatment. So this is a procedure that is used to remove excess fluid from the pleural space. That is the space between the lungs and, of course, the wall of the chest. And this is for what? A diagnostic what? Purposes. For diagnostic what? Purpose. So sometimes we analyze, not sometimes, we have to analyze the how do you call it? The fluid to know what is the cause of this fluid. Don't forget, pneumonia can lead to what? Fluid accumulation in the pleural cavity. It can lead to pleural effusion. Pneumonia can lead to pleural effusion. The same way, pathology from the heart can also lead to what? To pleural effusion. So you must know where this pleural effusion is coming from. And this brings to the concept of the Reval test or the Reval test. This is a test that is used to check for the presence of a transudate or an exudate. I repeat, to check for the presence of what? A transudate or an exudate. Transudate or an exudate. Now, a transudate is a fluid that is caused by mainly systemic conditions. Mainly systemic conditions that alter the pressure in the blood vessels, causing fluid to leave the vascular system. That is a transudate. I repeat, so anytime there is pressure in the blood vessels, fluid automatically leaks out from the vessel and can accumulate in the pleural cavity. That is a transudate causing that. And then we have an exudate. Now, an exudate is simply a fluid built up that is caused by a tissue leakage due to inflammation or local cellular damage. So anytime there is an inflammation or inflammatory process that is leading to accumulation of fluid in the pleural cavity, we call it what? An exudate. We call it an exudate, an exudate, an exudate. That means it's as a result of what? How do you call it? An infection. Now, when they say Reval test is negative, it means that the transudate, it means that the fluid is a transudate. It is positive when the fluid is an exudate. I repeat, a positive test means what? An exudate, which could mean that it is an inflammatory process. Whilst a negative test means a transudate, meaning it is because of what? Pressure in the blood vessels. So now if you look at the option that we have over here, almost everything apart from cardiac failure can lead to what? An exudate formation, because they are all more of what? Inflammatory what? Process, of course, except the cancer, really. But they can all lead to what? An inflammatory what? Process. And that is why over here, our best answer should be what? A cardiac failure. Cardiac failure. That could be the cause of the effusion in this patient. That's over here. Your answer is a cardiac failure. I've taken my time to explain this for you so you can understand the difference between exudate and a transudate. And when you have a transudate, what comes to mind? When you have an exudate, what comes to mind? All right. So here, your answer is A. A 14-year-old girl has been presenting with irritability and tearfulness for about a year. A year ago, she was also found to have a diffuse enlargement of the thyroid gland. I know every question on the thyroid gland, you people, you already know it. This condition was regarded as a pubertal manifestation. It was regarded though. So the girl did not undergo any treatment. So they left it, thinking, oh, this is a pubertal manifestation. Now, the girl's irritability gradually gave place to a complete apathy. The girl developed a puffy face, soft tissues, spasticity, bradycardia, constipation, skin pallor, and gland density progressed. The skin developed a waxen hue. What disease can't be suspected? Ladies and gentlemen, the noble profession, you know this already. So, of course, your answer is what? Autoimmune thyroiditis. Autoimmune thyroiditis. You know these things already. You know them. All right. Okay. So we have in a maternity hospital, a newborn had been presenting with cough attacks after eating. Cough attacks after eating. Who can tell me the reason why they ask people not to talk when they eat? Who can tell me? Anyone?
You know, when you're talking, your windpipe opens up, so to prevent food from going inside there while she eats.
Wonderful. So that means that there is a connection, or there's a separation between food or things that enters into your esophagus and things that enters into your trachea, isn't it? And when that place is compromised, that is when we have what? Choking, isn't it? Or we can have what? Coughing, because it's trying to get rid of that substance in the unwanted place. That's it, by the way, but let's continue. This is just to take your mind to somewhere. So presenting with cough attack after eating. Now the child was discharged from the hospital on the 8th day due to a case of pneumonia. Now during the further 1.5 months, the child had 2 cases of pneumonia just in 1.5 months. Periodically, there are cough attacks after eating. So it always comes after eating, especially if the child lies on the left side. Objectively, the 2nd degree hypotrophy, isolated moist crackles, and dyspnea are there. Stool and diuresis are not disrupted. What diagnosis is most likely? So just as some of you, Nene rightly pointed, there's a difference between what? The esophagus and the trachea. These are 2 different tubes that are not connected. As a matter of fact, what can separate between them, I think, is the epiglottis, isn't it? That can, when you are eating, it will cover the windpipe, like he rightly said, cover it so that the food will not enter there. But when you talk, that place opens. But even this person is not even talking. Well, it's because there's no history like that. However, if these cough attacks are coming in because of eating or after eating, it tells you that those 2 pipes have been compromised. Those 2 pipes have been what? Compromised. And when that thing happens, what happens? It means that food substances can enter into a place it's not supposed to go to. A place is not supposed to go to. And that is why over here, your likely diagnosis or our likely diagnosis should be what? Tracheoesophageal what? Fistula. Tracheoesophageal what? Fistula. And this is simply an abnormal connection. An abnormal connection between the esophagus and the trachea. An abnormal connection between them. And usually, they're not supposed to be what? Connected in any way. So something has to separate them. All right. So over here, your answer is what? Tracheoesophageal fistula. So your answer is A. A 26-year-old woman who gave birth 7 months ago has been suffering from nausea, morning sickness, somnolence for the last 2 weeks. The patient breastfeeds, no menstruation. She has been using no means of contraception. What method would be most efficient in clarification of the diagnosis? So first of all, what are you thinking is your diagnosis? No menstruation, no use of contraception. Who can tell me? Oh, nobody? Sorry? Pregnancy, exactly. Pregnancy. So if you are thinking of pregnancy, we've said it countless number of times. If there's pregnancy, 2 things you have to do. Many ladies know them already. I mean, the first one, all of you know it. But the second one is what? Ultrasound. So either you do the beta ECG, beta HCG, beta H human chorianotropic hormone, Charlie. So that is what? The beta HCG. Or you do an ultrasound. So of course, many ladies know how to do this, use the kits to check for their pregnancy. But then, of course, the more detailed one will be what? An ultrasound. Ultrasound will show the baby. It will show Fifi, showing his leg, showing his face, showing his casted stomach. All right. So the answer is what? Is D, with his 1-pack stomach. All right. A 2-year-old girl has a medical history of a recurrent obstructive pneumonia. Recurrent. It's been reoccurring. Anytime I see this one, I remember my guy, Nene. Now, in the lungs, various moist and dry crackles can be auscultated. Breath sounds are diminished. Sputum is thick. Sputum is thick, viscous, and difficult to expectorate. Drumstick fingers and physical developmental retardation are observed. What primary diagnosis can be made? So the mucus is thick. That means that there's a problem with what? The sodium chloride channels. Problem with the cilia. All of these things have been compromised. And I remember Nene brought to my attention about what? The Cartagena syndrome. Nene, that's Nene's favorite diagnosis, Cartagena syndrome. So I can remember it. So in the exams, never forget it. But of course, over here, we are looking at what? Cystic fibrosis. We're looking at what? Cystic. And one thing about the Cartagena syndrome was that the heart moved to the right, isn't it? Nene, right? The heart moved, right?
Yeah, that's correct. That's correct. The
exactly. Yeah, that's one of the things. Good. That's one of the things that helps you to know that this is what? Cartagena syndrome. But over here, we are looking at what? Cystic fibrosis, which is the same as pulmonary mucoviscidosis. Pulmonary mucoviscidosis. Sometimes they'll tell you that sweat test is blah, 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 blah. Anytime they mention sweat test, start thinking of what? Cystic fibrosis. If they mention thickness of some of these mucous, cilia, please, starting off what? Either Cartagena or you're thinking of what? How do you call it? Cystic fibrosis or fibrosis. So here your answer is what? D. Please, if you're just joining us, know well that we have done all of these things in this should be in therapy. We've done it in our therapy presentation or basis. So do well to watch them. Do well to watch them on the website. All right. After a case of purulent otitis, a 1-year-old boy has developed pains in the upper third of the left thigh. Bone temperature up to 39. Body temperature up to 39 degrees. Swelling of the thigh in its upper third and a smooth out inguinal fold. The limb is in a semi-flexed position. Active and passive movement are impossible due to the severe pains. What diagnosis is most likely? And of course, over here, we are thinking of what? Problem with the bones. Because this person having what? Pains in those areas. And of course, you can't say this is sarcoma. You can't say it's a cancer. No. There's what? Infection. Swelling of the thigh in the upper third. Swelling. The limb is semi-flexed. The movements are impossible. So this means that there is what? Osteomyelitis present. And the spread is because of what? This otitis what? This purulent what? Otitis. And of course, that means the spread of the infection is by what? Hematogenous nature. Is hematogenous what? Nature. Or in nature, hematogenous. That means pass through what? The bloodstream to the bone to cause this what? Infection. And this is mostly common type of bone infection in children. And again, it normally occurs in areas of high metabolic activity. And you know the thigh area or the femur has very high metabolic what? Activity. And that is why over here we are having a problem with the femoral bone or the thigh bone. So here your answer is what? Acute hematogenous osteomyelitis. So your answer is D. A 56-year-old patient with a diffuse, they've already told you the answer. There is a diffuse toxic goiter, has ciliary arrhythmia, heart rate 110, 120, arterial hypertension, BP is 165. What drug beside? You see, they've given your mecazole. Why do you think they give the mecazole? It's because of what? Increase in what? Hyperthyroidism, or because of increase in thyroxine. So you have to prescribe what? The mecazole. So they say, what drug beside this should be prescribed? Don't forget, this person is developing what you call what? Arrhythmia. This is a question that Uche loves so much. But of course, unfortunately, his option is not there. But we're having what? Ciliary what? Arrhythmia. Ciliary what? Arrhythmia. And one of the drugs that we can use to help out with arrhythmia, apart from the amiodarons, the stuff that Uche knows, is what? Propranolol. So your answer here should be what? Should be E. Propranolol. Please. Please, the answer is E. Let me not bite my tongue, Biko. All right. A patient has been previously diagnosed with pheochromocytoma. I remember we had the interesting discussion over here. We talk about your adrenal glands and we talk about the 3 layers. I remember very well because Juma, one of you that answered this question. GFR, bad children, bad student, talking about when it gets deeper, it's sweet. Now, a patient has been provisionally diagnosed with pheochromocytoma. That means it is the medulla that has been affected, medulla. Now, the BP is within norm. There is a tendency towards tachycardia. No urine pathologies. The decision has been made to perform a provocative test with histamine. What drugs should be kept close at hand for emergency aid in case of a positive test result? Again, pheochromocytoma is a tumor of the adrenal gland tissue, basically the medulla. And you know that the medulla is responsible for production of what? Catecholamines. That is the release of what? Epinephrines, norepinephrines. And these controls heart rate, metabolism, blood pressure, blah, 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 blah. Now, in case of a positive test result, there will be an increase in a peripheral vascular resistance and a vasoconstriction. There will be increase in a peripheral vascular resistance and vasoconstriction. And that is why over here we have to give what? Phentolamine. And this is a competitive alpha adrenergic antagonist. It is an alpha adrenergic antagonist. And this will result in decrease in a peripheral vascular resistance and causes vasodilatation. And that's why over here we have to go in for what? For the phentolamine. Don't forget histamine is also part of the all those catecholamines products. It can form part of them. It can be part of it. All right. So that's why if it's a positive, that means you have to counteract it, isn't it? You have to what? Counteract it. All right. So your answer here is B. All right. A 54-year-old patient complains of weakness, weight loss, despite the unchanged appetite, frequent urination, okay, skin itch for 6 good months. Some time ago, the patient underwent treatment for furunculosis. Guys, furunculosis, frequent urination, and things like that. What comes to your mind? Who can tell me?
Diabetes.
Oh, Charlie, you people are good. So she has not been examined recently. There is malnutrition, dry skin with scratch marks. Lymph nodes can be palpated in the axillary regions. Changes in the internal organs are absent. What test must be performed in the first place? So you see, so when you see your furunculosis and you are seeing the history, already you have your answer. So you know the person having what? Diabetes. And if diabetes, what test are you going to do? Of course, fasting blood sugar. Guys, the answer is D. Sorry, the answer is E. We've done them. A child is 1 month, 10 days old. Gushing vomiting has been observed. Maybe gushing could be said as a projectile vomiting. Projectile sort of what? Vomiting. Okay, that means there's something blocking something to cause the projectile what? Vomiting. Since the age of what? 3 weeks. The vomit, Fifi, favorite question. The vomit volume exceeds the volume of the previous feeding. So that means that something is not going, isn't it? Or there's reduced going of the food to the next chamber. And that the vomiting is too plenty, isn't it? I think we will discuss it extensively the other time. Now the child is inert, skin elasticity and tissue turgor are decreased. Horse glass deformity sign is positive. The primary diagnosis, they didn't tell you the answer. There's what? Pyloric stenosis. There is what? Pyloric stenosis. And we know the pyloric part connects the stomach to the duodenum. And food from the stomach, of course, when digested upon, is called chyme. CHYME. This then passes through the pylorus to the duodenum. Now, in pyloric stenosis, it means that the pylorus is narrow. It is narrow. The lumen is narrow. And the lumen is narrow. It means less food is able to pass through. And of course, what is or how you're going to manage such patient, of course, is to just open it up. Isn't it? Yeah, just open it up. So either you insert what we call a stent or through a surgical curtain of the pyloric sphincter, known as pyloromyotomy. Pyloromyotomy. Me, my R and L have a problem, even though I'm not an Ashanti person. I'm not Fifi people. But mine, I said mine. So that's it as well. Of course, surgical procedure. You have to do a surgical procedure to open up the narrow pylorus, narrow pyloric part, the narrow pyloric part. All right. A 46-year-old woman complains of pain attacks in the right lumbar area, which radiates to the lower abdomen and nausea. So right lumbar, I'll put my hand at my right lumbar. Yeah, this is it. Good. Which irradiates to the lower abdomen and nausea. The kind of pain attacks has never been detected in the patient before. Survey X-ray of the abdominal cavity reveals no pathologic shadows. That means in the abdomen, no pathologic damage. Now, ultrasound detects a hyper-echogenic growth in diameter, which reflects sound wave in the enlarged right renal pelvis. Right renal pelvis. What diagnosis are you looking at for? What diagnosis are you looking at for? And if I can remember correctly, Eugenia has asked this sort of question before, Eugenia, and we said this is what? Renal calculus, renal stones. Yes, from this question, I said we are going to investigate if it's a tumor, because I may mention that in tumor too, we can have something like hyper-echogenic, isn't it? But I think later on, we went to realize that in tumor, rather, we have hypo-echogenic. Yes, but I said I'm going to research on it more and tell you guys, but then no one reminded me, so me too, I've forgotten. And I know Christopher will have to remind me on something. All right, but basically, over here, we're having what? A renal calculus. And we've done it before, guys. We've done this. All right. So don't confuse it with what? A cancer. Several hours before, a 28-year-old patient suddenly developed acute headaches and repeated vomiting, then loss of consciousness. Focal neurological symptoms were not found. Pronounced meningeal symptoms. Anytime I see pronounced meningeal symptoms, I know the question is bonus. BP 120/80, according to the clinical and logical findings, the patient was diagnosed. They like subarachnoid hemorrhage. Now, after administration of dehydrant, the patient's condition somewhat improved. What is the main component of further? It should be for further emergency care. For further emergency care. So this person having what? Hemorrhage. This dehydrant help the condition to improve, but we want to what? Stop the hemorrhage. So what do? You have to give what? Coagulant. And I think we discussed this before. And I think, again, I remember now making mistake on this question. I remember. Winifred, I remember.
It was me that made the mistake.
It was you rather. Oh. Sorry. Nah, don't beat me. Don't divorce me because of this, okay? Don't divorce me. Okay, so at least you can remember it. That's good. A 24-year-old man has developed increasing headaches, vertigo, diplopia, paralysis of the facial muscles on the right, choking during swallowing. Signs appeared 5 days of respiratory disorder. He was diagnosed with acute viral encephalitis. Determine the main direction of emergency therapy. Guys, this person is having what? Acute viral encephalitis. So what drug should be your drug? What should be your drug of choice? Who can tell me? Drug of choice is what?
Zovirax.
Yes, so you have to give what? Antiviral drugs. Exactly. Antiviral drugs. So your answer is what? Is D. A 23-year-old woman who works as a milk and dairy inspector after the miscarriage suffers from high fever, recurrent chills, excessive sweating, polydenitis, pain in the lumbosacral spine, swollen left knee joint, and large liver and spleen. What is your diagnosis, guys? Your clue here is what? Somebody who works with milk and dairy products. And usually these people, so that means this person could have injected or taken in what? A contaminated what? Or unpasteurized milk or undercooked meat from infected what? Animals. And that is called what? Brucellosis. Brucellosis. So brucellosis is simply a highly contagious zoonosis. When it says zoonosis from animal to humans, zoonosis caused by taking in of unpasteurized milk or undercooked meat from infected animals, or coming into close contact with their secretions. So again, this person works with those people. And of course, meaning the cows and all kind of things could also be the reason. But of course, over here, your answer should be what? Should be brucellosis. All right.